Medical College of Cornell University, and he's also Director of Training at the Personality Disorders Institute of Weill Cornell. Frank has been a very active participant in doing the really interesting work studying transference-focused psychotherapy and an overall psychodynamic approach, working closely with the group that Otto Kernberg put together many years ago, and I was involved with that in its earliest phases. They've just published a very nice book describing some of this work, and there's some interesting results we're anticipating from a big study that's been going on for some time. So there's Frank. Let me turn things over to Frank.
Is there another mic? Yeah. Okay, just in case that one. Okay, good. I want to thank you, John, and I wanted to thank the NEA.BPD for putting on this conference. I think these conferences are really important, and as we all know, BPD is a largely misunderstood disorder, and it doesn't get adequate attention, and it doesn't get enough treatment resources. I'll be talking about the work of a group organized under Otto Kernberg, as John said, but I do want to say at the beginning that John Oldham and also Harold Koenigsberg were charter members of this group. And if you think about that for a minute, we could say we have a little N of 2 study here that shows how well you can do if you leave this group. But I'd also like to argue that you can do well if you stay in the group as well. So, which way does this work? Here are some of the other principal members of our group. I won't go over everyone, but Michael Stone spoke here yesterday, and he only represented a fraction of his work yesterday, sort of the more extreme fraction. I would like to underline that he was really talking about antisocial patients in his talk yesterday. He has also extremely interesting work on people who fall more within the borderline range we're familiar with, and I would particularly reference his book, The Fate of the Borderline Patient, which is a sort of longitudinal study of 500 cases he followed, not totally structured study, but a very interesting naturalistic study. So I'll be talking today about transference-focused therapy, and I'd like to first discuss what that is. It's the first manualized psychodynamic treatment for borderline personality. I think it's important to talk about what psychodynamic means, because it's one of those terms we all use, and sometimes we forget what it means because it just becomes a term that's a descriptive adjective in and of itself. But psychodynamic means conflict and movement within the mind. The dynamic is the movement, and the psycho is the mind. And I want to emphasize that because in a psychodynamic treatment, we're focusing very much on the forces within the mind in conflict. I would argue that every mind, including my own for sure, is in flux and to some degree in conflict. It's a question of at what level are the conflicts and how successfully do you resolve them. And in this sense, I think it relates to a lot of the biological studies we've been talking about, because Freud, of course, wanted to be a neurobiologist, but he didn't have the means at his time in history. So we're talking about forces related to the structures in the brain that have been discussed earlier in some of the talks. We're talking about limbic system. We're talking about cortical systems. We're talking about tensions between the two. But in this talk, I'll be discussing something I don't think has emerged as much in some of the early talks, which is about the perception and the meaning that's attributed to things. I think this might get back to Andrew Scottle's question about why certain things are activated in the brain of a borderline that might not be activated otherwise. I'll be talking about a way of understanding a patient's mind, and in fact anyone's mind, that has to do with trying to tease out differences between internal reality and external reality. I don't think any of us has a perfectly objective grasp of the world around us, and we all try to approximate our understanding as best we can to the complexity of the world around us. But in our work, we find that borderline patients have a particular structure of the mind that is very rigid and limiting and sort of predisposes them to read meanings that may not be there in objective reality. So I'll be talking about that. But I also want to talk about the fact that we were the first manualized psychodynamic. Bateman and Fonagy have now published a second manual involving psychodynamic therapy, mentalization-based therapy, which is very interesting. And to pick up on what John Oldham said, a lot of these treatments have commonalities. Certainly, a lot of what I probably won't have time to discuss, but in terms of setting up the treatment, Marshall Linehan and we have a lot of overlap, the hierarchy of priorities that need to be addressed before the rest of the work can be done. But I want to address just for a second this question of why manualized treatments, because really for two reasons. One is that psychoanalytic and psychodynamic therapists are famous for doing whatever they feel like in their offices. They have very nice theories, but over time it seemed like they could just sit and say or not say whatever they wanted, and it became sort of a caricature. So when you're talking about psychotherapy these days, it's actually at your own risk that you say you're psychoanalytically oriented, because in a lot of people's minds, psychoanalysis is just a historical thing now. But I would like to argue that if it's manualized, if it's systematized, so it can be done in a more predictable and more technically rigid way, then it becomes much more relevant. And actually, I think this is relevant to the study that Alan Frazzetti mentioned in Seattle, because to my knowledge, there are no psychodynamic therapists in Seattle who follow a manualized model of psychodynamic. And in my own experience in New York, I see a lot of very well-intentioned psychodynamic therapists who try to treat borderline patients, but unless your treatment is specialized, you usually don't do very well with this population. And I make the analogy to surgeons. If you're a general surgeon, you don't want to do cardiac surgery. And if you're a general psychodynamic therapist, you don't want to take on borderline patients. I think this is one of the things that Otto Kernberg contributed. He contributed both to our conceptualization of the disorder, but he also contributed on structuring a psychodynamic treatment in a way that's specifically modified for this patient population. So, I also want to mention, in terms of our development in the treatment we offer, that we call it a hospital without walls model. We used to have a system at the Westchester Division, where John and Harold were many years ago, where we could treat patients over a very long period of time inpatient. That possibility does not exist at this point in time. And we would do a lot of different things with people. And Dr. Bohas mentioned some of what they do in Germany now. There are many components to the treatment. By force of economic realities, we've had to treat a lot of the patients we used to treat as inpatients, as outpatients, but we have different components. This is not a twice-a-week psychoanalytic therapy in a vacuum. If family therapy needs to be a component, it is. If substance abuse treatment needs to be a component, it is, and so on and so forth. So it can be within the context of a bigger framework. So I'm going to talk some about the theory that's at the root of what we do. It's based on what's called object relations. I'll be talking more about that later. And it aims at changing underlying personality structure, or what we call deep personality change, as well as behaviors and symptoms. And, you know, the whole concept of personality is much discussed. It's one of those words we all use, but when you start to define it, it's a little hard to pin it down. But I'll be proposing to you at least a particular model of personality and how that model affects the person's experience of life, of themselves, and of the world around them, and how we think that can change with this treatment, certainly possibly with other treatments. If time permits, I'll talk about 3 studies we've done so far. By the way, I'm very envious, of course, of the DBT number of studies, but psychoanalysts are a rather difficult bunch. A lot of them don't think you should study their work at all because it's too rarefied, so I won't go into that problem. But in any case, we did a first one using patients as their own controls, a pre-post study, then using a non-randomized comparison group, and then in our largest study, which is coming out in a few months, a randomized control study of patients in TFP, DBT, and a supportive psychodynamic therapy, a manualized supportive therapy. There is no treatment as usual group here. We thought we would compare it to 2 other active treatments, so I'll try to get to that later. Now, one thing about TFP and about Kernberg's conceptualization of personality disorders is that it's applicable for patients beyond the more narrow DSM-4 definition of borderline. Now, I'm going to show you this slide. for 30 seconds and then have you reproduce it at the end of the talk. Sorry. This is something I'll just speak about for a moment. Kernberg he's a little obsessional, and he loves to sort of make maps and things. And this is his map of all the variety of different personality disorders, of which borderline is very central. But he finds, and of course we find in our clinical reality, narcissists who might not fit the DSM-4 definition of borderline. They might not cut or take overdoses or have exactly the same kind of impulsivity. You have dependent, sadomasochistic, avoidant. A lot of these are in DSM-4 and a few are not. But the point I want to make in this slide is this whole area between the top line here and the lower line here. This whole area is what he calls borderline personality organization. And the relevance of that to what I'm going to be telling you is that we feel that this model of treatment can be applicable to the different disorders beyond the borderline as narrowly defined by DSM-4. Now, it's interesting because when Jeremy Coyd presented his study yesterday, he didn't find many narcissists. I asked him about that yesterday evening. He said, well, I was in New York where we had a lot, and he was in England where they didn't. But in any case, we have a lot of narcissistic patients, and they're a little harder to treat in a way because they don't have the obvious acting out symptoms that everyone can agree is pathology. So anyway, that's a point I may or may not be able to elaborate a little bit more. But I want to get to what we see as the underlying psychological structure that we think links all of these different diagnoses. So first of all, how do we consider this broad category of borderline organization? We think it's based on a problem of the self, on what we call identity diffusion, a lack of a clear and coherent sense of who one is. And corresponding to this lack of clarity about who one is lack of clarity about who others are. I mean, we all know about borderline patients having extremely rapid shifts in the sense of the moment, who they are, how they feel, how they experience the other person. We all have personal and clinical examples of that. So the sense of self is split and fragmented, also distorted. This is where I'm going to get back to why borderline brains may be active in different ways, because their perception may be distorted in a way so they see these neutral images as negative, not because of something outside, but because of something they project onto that image. So this all leads to difficulty reading others and also reading one's own emotions, sense of emptiness, a lack of continuity in time. These are all very distressing things. Primitive defenses, especially projecting negative aspects of the self. Defenses, even primitive ones, serve a purpose. Now, everybody talks about primitive defense mechanisms as though they're bad, but they do decrease anxiety. If you've got an affect you can't cope with, you can't tolerate in yourself, a way of dealing with that, we feel unconsciously, is saying that it's outside of you. So it's still a problem, but it's less of a problem than if it's part of you and you've got it right there within yourself. So we feel there's a lot of projecting going on, which I'll talk more about. And a lot of our treatment is trying to help people embrace sort of the totality of their experience, which they aren't able to embrace at the beginning of the treatment. And as John Oldham said yesterday, we see in this level of personality disorders variable reality testing. Mostly they know what's going on in the world around them. Under stress, the distortions can become major. So in this group we find intense affects, disturbed interpersonal relations, difficulty with sexual functioning. We did a study. We sorted out two groups. One had very promiscuous, chaotic sex life. The other had none at all. You can find moral rigidity or an absence of moral values, difficulty with commitments to love and work, and the family stress and burden we've been talking about. I'm actually going to skip back to this slide because in our experience, and one of the themes of this conference has been, I'm not supposed to move, how variable borderline patients can be. And on this vertical axis, it's called mild severity to extreme severity. Another way of conceptualizing that is mild aggression versus extreme aggression. Aggression has been much discussed here, and Kernberg is sometimes criticized for focusing too much on aggression. So I asked him about it, and he said, I don't love aggression, but I think it's important for 2 or 3 reasons. One is because it's there. It has to be dealt with. Evolutionary, it's just part of the human being. Second is difficulties with aggression can be an obstacle to difficulties with love. So you've got to deal with aggression. You've got to get it in order so the more loving instincts can come out. And third, in its sublimated forms, aggression is a great thing. It can be behind creativity, motivation, achievement, so on and so forth. But if we were to get into more of the details of TFP, your interventions would be a little different with this group, where aggression is more of an issue, than with this group, where inhibited loving expression is more the issue. So, moving on. What are our goals and objectives? First of all, this is the phase of treatment I won't be able to discuss very much, but we have to contain the acting out behaviors. So we put a big emphasis on structuring the treatment through the treatment contract. Then the rest of the work is to resolve this identity diffusion, this fragmented and uneven sense of self that we feel these individuals go through life with. And we do this by fostering reflection on mental states of self and other. This links it with the MBT, which is about reflecting about states in self and other. We feel the best place to reflect on self and other is in the relationship between the patient and us, because that's where it's happening in the moment. So, in practical terms, we have a treatment structured, as I said, by the treatment contract. We have 2 sessions a week, possibly with adjunctive treatments. Duration is minimum of 1 year. As Alan Frazzetti said, most patients need more than a year, but our studies have shown us, to our surprise, how much change can happen in a year. So we're a little more encouraged about patients who can't have the longer treatments we usually find indicated. And as I said, it focuses on the immediate interaction between patient and therapist, because that's where we think the reality of the patient's mind or internal world becomes apparent. So I'm going to give you just a little bit of theory. This comes from a combination of Freud, Melanie Klein, and Otto Kernberg. Freud, of course, talked about the conflicts between drives and prohibitions against drives. You don't deal with those conflicts well, you get a neurotic symptom. Melanie Klein said, well, you know, drives aren't there in the abstract. If you feel a lustful drive or you feel an aggressive drive, there's always an object of the drive, usually another person. So she said what really goes on in the mind is the combination of drives and objects of the drives. So you've got to think, if you want to think about mental structure, about the drive in terms of how the self is conceptualized when it's experiencing that drive or affect. I won't go into it now, but there's a debate about which comes first, drives or affects. Affects are in any case what we observe, so we'll call them affects here. So the theory is that to understand the mind, you have to understand how a person sees him or herself, how he sees the other person involved, and how he's experiencing that emotionally or affectively in the moment. So, in terms of a very brief overview of a developmental theory, the way we sort of understand things, under peak affect states, an infant, any infant, we're talking about normal development for the moment, internalizes a memory of itself in relation to the other, the caretaker. Now, this, of course, can be an experience of very different qualities. So at one point in time, to give you the classical example, the infant is hungry, soiled, wet, cold, uncomfortable, cries out for help, and the caretaker's there, nurtures, nourishes, soothes, and that's a positive experience of self and other, linked by a positive affect, warmth, love, and so on and so forth. Now, in any development, you're going to have the same initial situation of pain, discomfort, need. You're not going to have a response from the other. So that will be the internalization of a very different representation of self and other. The self will be in pain, will be frightened and anxious. The other will be neglectful, maybe intentionally harmful or abusing, will either be the reality or the perception. Now, this is where we begin to talk about the difference between the internal world and the external world. Because as we've heard earlier in this conference, some families and parents are overtly abusive, but on the other hand, a caretaker might not be able to respond to the need because they might be ill, they might be dealing with another child, they might be in the hospital with a depression. There could be any number of reasons that the wished-for response isn't there. So our hypothesis is that in normal development, this is point number 3, the extreme positive and negative segments of the mind become integrated into a more complex rich and nuanced version of reality. In other words, you go beyond seeing the world in terms of black and white. By force of cognitive learning and by force of, in most cases, a predominance of good experience over bad, the individual is able to realize what we call good enough experiences, good enough mothering. It's a wonderful concept. And a good enough self. However, what we find is that borderline pathology develops when either under the stress of maltreatment I should have and or aggressive constitutional loading. As John Livesey said yesterday, this is very much a genetic disorder. The negative experiences take on a preponderance of importance. It makes it more difficult for them to be integrated with the positive experiences. And when these negative experiences remain isolated and split off from the positive, you don't have the integration that we feel is necessary to have a realistic, complex experience of self and other. So this is what we call the state of identity diffusion, and we think it perpetuates perceiving self and others in extreme absolute terms. So, schematically, this would be a representation of what we call the split internal world. Things are either black or white, all good or all bad. You're in a good position and you're being well taken care of, or you're being totally neglected. And in terms of, well, I'll get to that in a clinical example in a minute. And this is what we see as the integrated world. Nobody's perfect, but people can be good enough. The interesting thing is that in this slide, you actually have something desirable. You have perfection. And I find it very appealing about a lot of our patients because they have a real kind of romantic wish for, longing for, and belief in perfection. And if you really want to get better, you kind of have to give that up. One of my patients, after 2.5 years or so of treatment, very difficult acting out patient, said, you know, you've helped me a lot. I love my husband now. She used to fight with him all the time. Sometimes he'd have to call the police. And, you know, I'm not acting out, and things are going so much better in my life, but you took something away from me. She said, I used to believe in the ideal perfect love. And you've made me see that doesn't exist. It's kind of sad. It's like when you realize Santa Claus doesn't exist. So we all have to go through that or not, depending on how we choose. The other thing I would argue, by the way, is that I don't think there's a totally rigid division between the split organization and the integrated one, because remember, I'm talking about a mind in flux. As I said, we all have things going on dynamically in our mind, and one could argue that in certain situations, any of us, can function in this split way. I mean, if you fall in love, you're infatuated. That's kind of a regression to split because you think the other person's perfect. The real problem is when you find a fault in the other person, can you stay in love because maybe you can accept an integrated view, or do you just move on to the next, as we see in a lot of our patients? The other thing, and I really can't get into this, is that in large unstructured groups, very mature people can regress to very split thinking, and that has all sorts of political implications about fundamentalism, so on and so forth. So I think this theory has many different applications, but we can't get into them now. So what we're trying to do is get somebody from the split organization to the integrated organization. I put the Kleinian terms in parentheses, but I won't discuss them now. So we do this by trying to integrate what's split off within the self and project it onto others. And why do we feel the focus of the transference helps? Well, if you take what might be a typical mind of a borderline patient, there are a fixed number of these, what we call object relations dyads, where the person can experience self and other in extremely different states, from a positive state to a negative state, and to shift with no awareness. The interesting thing about it is that all of these are true. It's not that one is true and the other is not. A patient of mine started a session, again, back when we had patients in the hospital for months, and she'd been seeing me for quite some time, and she started the session saying how she was so lucky to have me. I was the only therapist of her multiple therapists who knew what he was doing, and it was wonderful, blah, 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 blah. And then I don't even know what I said in the middle of the session, but she turned on a dime and said, I don't know why I come here. You're useless. She went down to the unit, gathered all the other patients in the unit to denounce me and tell them how bad I was. So in any case, both of those things were true in her mind. But if that's the way you think, if that's the way you experience reality, if that's the way you function, you're not going to get too far, and you're not going to be too happy. So in any case, The reason we focus on the transference is we think that's where all of this reality of the patient's internal world comes out. We're playing two roles vis-a-vis the patient. We're a person who's there to help them reflect, but we're also offering ourselves as the surface for the projection of their internal objects. Just to give you an example, patient of mine I've been seeing for a few months, 9 o'clock appointment. I get there, just to fill in the story, it was a snowstorm and I had 30 miles to drive, so I was pretty happy I got there on time. You know, it can be tricky driving in New York in the snow, so I thought I was being a good therapist. So I get there right at 9 o'clock, say hello, I'll be with you in a minute, walk from the waiting room into my office, take 3 minutes to do a phone call about a situation I had to make sure was in order, open the door to the office, to the waiting room, patient's running out of the waiting room. By the way, I should have started by saying this is a patient who for 3 months had told me that all of her problems, her suicidality, her depression, was because of her mean, horrible husband who treated her badly and was a monster. So anyway, for all I knew, that was real. And if that was real, my therapy wasn't going to change things very much unless I told her to get a divorce. So in any case, I open the door 3 minutes after 9. She's running out. What do? You might be surprised. I'm an analytically inclined therapist, but I run after her. You have to be more active. That's part of the change in model. So I run after her, but she's faster. So she jumps in her car. I wait the 15 minutes it takes to get to where she lives. I call her up and I say, what's going on? She said, well, you kept me waiting. Now, that's a reality we agreed on. But this is where the distortion begins. I said, yes, I did keep you waiting. She said, well, that proves what I always knew. You hate me. You don't want to see me. You wish I weren't your patient. So this is where we begin to get what we consider a part of the internal world that is not acknowledged and is seen as an external reality. Now, to make a long story short, often these patients have trouble with their own angry, aggressive feelings, which, interestingly, they can act out very well, but not have an awareness of, because any awareness of it is forbidden to them. So this is why we think that by allowing that internal world to just unfold with us and then help the patient observe it, they can begin to integrate what they haven't been able to so far. And I'm going to give this as another clinical example and then skip on to some of our research. There are a couple of interesting ways these dyads can interact, and the first one is what we call oscillation. That's when you have a given dyad, a very classic one being the victim-persecutor dyad, and the two roles change suddenly and without any awareness on the part of the patient. I give you this example because I think it'll help see how we work. I had a patient come in, again, a few months, maybe 6 months into treatment. In spite of her illness, in spite of being hospitalized a number of times, in spite of angry acting out, self-destructing acting out, she managed to go through social work school, which was quite an achievement. So she walked into my office, noticed a book on my bookshelf, and said, oh, gee, that's a book I've really wanted to read, a book about psychotherapy. May I borrow it? Now, that put me right away in a situation I wasn't prepared for. I said to myself, well, I could lend her the book, but I said to myself, and this actually gets back to what Alan said at one point, we all need a structure. The structure is as much for us as for the patient. I said to myself, my job is to explore things. So before I decide whether or not to give her the book, let's look at what this means. I said, it's interesting you've been coming here for 6 months. First time you've asked me for something. I wonder what that means. Which I didn't think was too unreasonable a question. She jumped out of her chair, said, you fucking bastard. You're just like the rest of them. I can't get anything from you. You don't want me to succeed. You're against me, blah, 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 blah. And she started pacing back and forth in front of me, waving a can of Diet Coke like she was going to throw it at me. So I was a little anxious, but I referred to my theory. This is where the structure helped me. So I said, gee, what's going on here? I think there's a reversal. I think this is an oscillation of a dyad. She, interestingly, is still experiencing herself as the victim of my being a mean bastard, but I'm experiencing myself as being the victim of her anger and rage. So I tried to engage her observing ego, or in what we might now say current terms, reflective functioning. And I said, hold on a second. I have an idea, but you're interested in hearing it, because if the patient isn't ready, you wait. So she said, what's your stupid idea? So this is where I try to be the two people. I didn't say, I really didn't treat you that badly. But I tried to get her to observe things. I said, well, suppose you're a person walking by this office looking in the window. Hibernate. Whatever happens, can somebody fix it? What should I do? Oh, here you go. So in any case, I said if you were a person walking by this office outside looking inside, what would you think was going on? And lucky for me, because sometimes these things don't work right away, lucky for me, she said, well, you know, I guess I'd look like I was pretty angry and treating you pretty badly. I said, well, yeah, maybe. And I said, but the problem is, it's hard for you to accept that. And then we do something which maybe we don't write enough about. We normalize the affect. We say, you know, everybody feels like that sometimes. Problem is, it's hard for you to accept that. It's hard for you to see that as part of yourself. And the problem is, if you can't see that as a part of yourself, you have no mastery or control over it. It controls you. Thank you. So, that was just in time, by the way. So I hope that gives you just a little idea how we go about trying to deal with affect regulation through the level of the perception of the reality. We also do, we didn't use this term, but we do a lot of validating because we can say, you know, if I saw things that way, I'd react that way too. I'm just wondering about seeing things that way. So, I've gone through this. Our interpretive process, I won't go into great length here, but interpretation is under attack these days. A lot of people are saying it's not good for patients. It's either too intellectual or it imposes an idea on them. But I think if you do it the right way, it's very helpful. You have to start very experience near. So as I just said, you might say, you know, if you see me that way, it would make sense to react that way. And as I said, you know, it's hard to accept in yourself what we're seeing now. Or we might say, you know, we agree on the affect in the room, but we're not sure where it's coming from. And as I said a minute ago, if you can acknowledge this, that it's a part of you, then you can gain mastery over it. So I won't go over the steps of interpretation. That's probably for another audience. Not devaluing this audience, but an audience where we have more time. But I just wanted to say we've tried to put together our mechanisms of change. We set the frame of the contract so that the patient can experience a safe haven to express and experience everything that's in them. Most places in the world don't allow for that. You know, most people run for cover when some of these emotions get expressed. So we create this safe haven. Then the expression of affect includes interactions based on those internal dyads that gear or guide or determine the perception of internal reality. We observe without judging. Then we go through a process of clarification of what's being felt, confrontation if there are discrepancies in what's going on, and interpretation, trying to help the person understand where things are coming from. We think this increases their capacity to reflect. As the affect regulation increases, so does the capacity for reflection. It becomes a positive circle as opposed to a vicious circle. So I'll skip over a couple of these. And as we all know here, the family is very important. In terms of TFP, we don't go by the old analytic rules of no contact with the family. The family can call us with information. We want to know if they have concerns. But if the patient wants confidentiality, they have it, except for what are we doing here? Except for situations of emergency. Did we know what happened here again? Okay. But in any case, I might have to turn to my, if somebody can hand me one of those, because I know I'm running out of time. Okay. Okay. I'm not quite sure what's going on. I don't know. All right. Well, just in terms of, for the sake of not going over time, if you turn to, is it 9? Yeah, let's move on to page 10 in this handout here. We did 3 studies. I'm going to go over them very briefly. And the first one, as I said, was a pre-post study. We studied 17 patients, and we got data on them for the year before treatment and the year during treatment. And just to quickly review the slides, which aren't there, we found that the percentage of patients attempting suicide decreased dramatically, as did the percentage of patients who were hospitalized. an even bigger difference in the number of days hospitalized, and a significant increase in the global assessment of functioning scores. Okay. So, moving on to page 12. In our second study, we did a non-controlled but a comparison study between patients getting TFP and patients in our OPD who were similar diagnostically but were not in our manualized treatment. Now, I presented this in one place who said, look, in your hospital's OPD, isn't TAU going to be the same as what Kernberg teaches? My answer to that is I wish it were. Our OPD does a kind of a all over the place TAU. So in any case, in study number 2, you can see the bar graphs that compare the two groups, those who were treated for a year with TAU and those who were treated for a year with TFP. And we have similar results, which is that in the course of a year, the percent of patients with ER visits declined significantly with TFP, not with TAU, as did the percentage of patients hospitalized. And once again, the number of days in the hospital decreased for the TFP group but not the TAU group. And the global assessment of functioning score increased significantly for the TFP group but not the TAU group. But I did want to get to our RCT, which is, I think, impressive at this point. And we chose to study 3 active treatments. I mean, it's interesting to study treatment as usual, but I think to some degree we took advantage of the fact that DBT has such a track record of studies showing they're better than TAU that we thought an interesting question might be whether we could do as well as DBT. So, skipping ahead, you've heard about DBT. I've told you about TFP. As I said earlier, the supportive psychodynamic therapy was a manualized one carried out by Ann Applebaum. Some of you know her in this room. She's not somebody to do things in a shoddy way. And in terms, wonderful. I'll try to be good. It's a little further. I can control it now. Yeah. So, all right. We've been through these slides. Study 2. And study 3 I was just describing. The 3 treatments. And the therapist, I think it's important that in this study, each cell leader, the DBT leader, the TFP leader, and the supportive leader, chose his or her own therapists. And our DBT cell leader was Barbara Stanley, who's been funded and worked in DBT, so we figured she knows what she's doing. And each group had was supervised weekly and monitored for adherence and competence, which are big issues in any therapy study. You have to wonder if people are doing what they're supposed to be doing. So in any case, I'm not going to go over the demographics, but here's what we looked at. Primary outcome measures are suicidality, aggression, and impulsivity, and treatment completion versus dropout, which we consider to measure alliance. And then some secondary measures, global functioning, social adjustment, depression, anxiety, irritability. And we're getting into that stage where we're beginning to wonder what the mechanisms of change are. So our hypothesis was that our work with patients would increase their ability to reflect accurately on themselves and others. So just to look through what we found, in terms of these particular symptoms, all 3 treatments help patients with depression, anxiety, global functioning, social adjustment. DBT and TFP helped with suicidality, but the supportive didn't. In terms of other domains of change, TFP helped improve impulsiveness, the Barrett 2 impulsiveness. Supportive improved the Barrett 3 impulsiveness. DBT didn't seem to have an impact on impulsiveness. In terms of irritability, anger, direct assault, and verbal assault, TFP patients showed improvements in all these domains, with DBT showing improvement just in the anger category. So, to summarize, there was significant improvement in DBT and TFP, but not in supportive with regard to suicidality and anger. Significant, for some reason the slide about dropout wasn't here. We had a finding that was not like what's in most DBT studies, because in this study there are more dropouts from DBT than in the TFP or the supportive, and significant improvement only in the TFP group in verbal assault and direct assault, no improvement on the Barrett number 1 impulsivity item. Now, first of all, I think these are great findings because it shows that treatments help, but we wanted to see if there's anything specific about what we do. So we got to this question of mechanism of change, and we addressed the question, which has been addressed more broadly, what happens to people in therapy that leads to the change? And there's a very interesting issue of the Journal of Clinical Psychology last spring where people from all these different schools and others wrote articles about what they think changes in their patients and their treatments. So we feel that in TFP you have increased differentiation and integration of self and others, a more accurate view of self and others. And when you begin to look at these psychological variables, it's harder to get instruments to accurately measure them. So you have to see what can approximate your concept best. So we decided to use reflective functioning and mentalization as an approximation of the kind of improvement in self that we were looking at. So just to define the concept that's been developed by Fonagy and Tarja and Bateman, mentalization is the social cognitive and affective process of interpreting or making sense of behavior in oneself and others. Again, it gets back to perceptions. In terms of intentional mental states, what does the person mean or mean to do here, such as desires, feelings, and beliefs? Reflective functioning is defined as the capacity to think or to mentalize in terms of mental states, to accurately know, be familiar with, name, and manage your own mental states, and to accurately perceive and deal with the mental states of the person you're interacting with. And there is a scale that goes from a -1 to a 9, -1 being these are rated on an interview called the adult attachment interview that some of you might know. And the text of the adult attachment interview is studied for the answers in terms of how much they show good reflective functioning or poor reflective functioning. And what we found was that our hypothesis, at least in this one study, seems to hold up, that in TFP there was a significant increase in reflective functioning, and in the other two treatments there was no significant improvement. So our hypothesis is that we feel that if this finding holds, if this could be repeated, that this may be an important mechanism to help a patient not only change symptoms, but to have a different conception of self. And we also believe with better reflective functioning, the person will be able better to maintain gains over time. Because in a lot of studies, it's been shown that there's improvement during the course of the treatment being delivered, but once the treatment ends, there's a falling off of the improvement. So our plan is to follow up this study. We're doing a long-term follow-up, and we're having a study done in Europe at this point to try and repeat some of this. But I think I probably am about out of time. So. We have time for questions? Okay.
I think one thing we've discovered is that being experienced in TFP trains you to be nimble and prepared for anything.
Adaptability.
And adaptable. And Frank did a wonderful job of shifting media, moving from slide to paper and back, while it turned out the plug in the floor unaccountably died. And it was running on battery.
I thought it was me.
It had nothing to do with
Well,
you.
that's my internal reality.
Do we have any comments or questions? Because we could take a minute for that. Paul Solo.
One of the key concerns here is whether non-dualized treatments will be generalizable to the practitioner in the community. DBT has made a considerable, the folks behind DBT have made considerable effort to train therapists in the community and shown that it's possible to do that in a matter of weeks to months. Is transference-focused psychotherapy going to be translatable to clinical practice?
That's a question we're addressing. It's a great question.
Repeat the question.
Oh, the question is, about the translatability of a manualized model of treatment from an academic setting where there's more rigorous control over what's going on to a community setting where people practice without as much supervision. And that's a question we're trying to address. We're teaching TFP in a number of places, interestingly more in Europe and other countries than here, although in some other places here. I think this, in this country, there's a big emphasis on cognitive behavioral treatments in most departments of psychology, whereas in Europe there's still more of an interest in the dynamic tradition. But we have groups in Munich and in Vienna and in Amsterdam and in Quebec and in a number of other sites where we're trying to translate this, but the results aren't in. That's an important question.
Okay, I think we'll. Oh, Pat, one last question.
Did you actually do the adult attachment interview before and after?
Yeah, it's a lot of work.
Repeat the question.
Oh, the question was if we did, because Pat knows, the adult attachment interview is a long, very labor-intensive interview. And one of our psychologists, Diana Diamond, convinced us that it would be worth the time and effort. And I think she's right, because without that we wouldn't have been able to get the reflective functioning finding, which is important to our hypothesis. But you're absolutely right. It was a huge amount of work.
Okay, thanks, Frank.
You're welcome.
Let's give that to Andy. All right, we're going to move on.